Okay, here ready to continue with blood, with platelets. So let me get this going again. So up to this point, we have covered the red blood cells, the erythrocytes. We've covered the white blood cells, the leukocytes. We're seeing that blood is a little bit more complex than just blood, right? It's not just this red liquid. It's got all these other parts to it. So we move on today now to the third of the what we call formed elements, which are going to be platelets. So platelets are derived from that same cell, right? So very critical cell, the hemocytoblast. Hemocytoblast having this developmental path, changing into this what we call megakaryocyte, mega big, karyonucleus, cyte cell. So cell with a big nucleus. That's what that translates to. And basically, let's say that we're eating chips, we're eating Doritos or something, right? We're eating and little crumbs fall. That's what platelets remind me of. The platelets are little fragments of cytoplasm, little fragments of granules that fall off, and those have their own separate sort of functionality. They're their own entities. We don't call them crumbs of a megakaryocyte, we call them platelets. So these are these little fragments that are going to be very critical in the stoppage of bleeding, right? So platelets, we can give them a fancy name. We can call them thrombocytes. They're not technically complete cells, so I don't think that's a complete valid term, but it's accepted. Yeah. So thrombocytes, or these little fragments, these platelets. So platelets are not cellular. They're not complete cells. They are nothing more than cytoplasmic fragments of very large cells called the megakaryocytes. So these big megakaryocytes. The platelets' primary role is in the process of hemostasis, the stoppage of bleeding, right? So if we have a tear on the blood vessel itself, the platelets are going to help. They're going to go into the process to help sort of clog up that bleeding. Platelets have granules containing chemicals that act in the clotting process. And there's our little granules. These granules are very different. They're not the lysosomes themselves. These are granules that contain a lot of different separate, different types of clotting proteins, different clotting factors, right? So these clotting factors are going to help in the hemostatic process, the stoppage of bleeding, right? So hemostasis itself is not just one thing, right? Hemostasis is a process. It's a process that involves then the bleeding or the stoppage of bleeding. So hemostasis will involve the release of substance, the release of platelets, and these clotting factors. So we're going to say three things are going to happen, and we presented here with the blood. It does have relevance with the blood vessels themselves, right? So three controlled events. Oh, got a little cut, little injury. So we're going to have first the vascular spasm. So the blood vessel itself, the smooth muscle, will contract. The platelet plug formation. So these little clotting factors will actually form a plug. They coagulate, and they actually kind of will seal off that bleeding. And I'll show you some pictures, and I'll try to upload a little video that shows that process as well. So vascular spasm, an immediate temporary constriction of the vessel, right? So that vessel wall will constrict. So we have an injury, and I hope you can see how logical this is. If I have an injury here, if I can constrict, I will slow down the flow of blood to that area. So the smaller the path, the slower and less cells that are going to be passing through there. So we'll minimize the loss of blood in that situation. So any injury to the smooth muscle, and we're going to talk a lot more about this when we actually define the anatomy and the physiology of the vessel wall, but for now, so blood vessels can vasodilate, get bigger, or vasoconstrict, smaller. So that is due to the smooth muscle. And smooth muscle, if it's injured, it triggers this spasmic process. Chemicals released by the endothelial cell wall, or I should say endothelial cells of the vessel wall. We'll talk about those. Platelet factors, and then just reflexes. Anytime you have pain, it causes that reflexive spasm there. So step one. So there's the spasm, right? Two is a little bit more elaborate. Two is going to take a lot more biochemical processes, a lot of more chemical reactions to generate that plug. And they make it seem very simplistic here. It is kind of involved. There's a lot of stuff going on. And then lastly, three is the coagulatory process. So I'll address these in the video. I think it'll do a lot. It'll show it easier than just trying to look at a static image here. So going here to coagulation, right? The coagulatory process. This is basically a long step, a lot of chemical reactions that will end up in this molecule that we call fibrin. So what is an actual blood clot? It's an aggregation of fibrin, right? But fibrin doesn't start out as fibrin, right? Fibrin has to be, the formation of fibrin has to be triggered, has to be generated, yeah? So the formation of blood clot depends on a number of proteins called coagulation factors. And if you remember from 13.0, or I should say 24.01, the ever-present role of calcium, right? Should be two positive charges. Calcium, the double cationic charge. So coagulation factors, calcium, all help this feedback process, feedback mechanism, biochemical pathways to lead to fibrin. So this is a video, I'll upload it separately. So clotting pathways are basically going to end up in the same place, but they're going to have different beginnings. So there's two separate pathways that can undergo, or that can happen, that can follow to lead to fibrin. So two separate pathways, the extrinsic pathway and the intrinsic pathway. Right? So both pathways are usually triggered simultaneously during tissue damaging events. And it just takes that one event to trigger, and this knocks this domino down, knocks the other domino, knocks the other domino. And this chain reaction of events leads to the clotting pathways, or leads to the actual fibrin via the clotting pathway. Now, a lot of stuff, right? A lot of details here. Whether you are going to have to know these details will depend on what field you go into. Right? If you're a sonographer, you're not, okay, you're going to memorize this and you're never going to use it again probably, right? All you care about is that bleeding stopped. If you're a surgeon, if you're a doctor, well, this is going to become very critical. You have to know the sequence of molecules that are being triggered, right? So I will present them here. I'm not going to be that particular in the introductory anatomy class, but it's a neat little, very informative slide that you have here. Right? It's in the notes. So clotting factors, 1, 2, 3, 4, 5, 6, 7, da, 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 da. And unfortunately, the clotting factors are named in the order they were discovered, not in the order that in which they work. So that gets a little bit confusing sometimes too. So some of the factors themselves, right? Fibrinogen, prothrombin, tissue factor, calcium itself is a factor protein, or I should say a factor. So a lot of different stuff here. If you notice, most of these are coming from the liver. So if a person does have some sort of trauma, cirrhosis of the liver, hepatitis, some sort of liver trauma, it's going to have a harsh effect on liver functionality, on symptoms derived from the hepatocytes, but it's also going to have a negative effect on blood clotting, because many of the clotting factors are derived from the livers, or the liver cells. Right? gives you a little bit of an idea of what they do here. Right? And what are they? They're actually proteins, ion, proteins. So most of them are proteins with the exception of calcium. All right, joy and fun. Pathways, clotting pathways, right? So the moral of the story, right? Trying to keep it as streamlined as possible. We start here, we end up here. So regardless of where we start, intrinsically or extrinsically, we end up in that prothrombin activator. So that's what's going to be addressed in the homework, right? This common molecule, this prothrombin activator, could have been initiated by what we call tissue factor. So tissue factor we associate with the extrinsic pathway. Intrinsic we're going to associate maybe with the collagen. Right? So collagen, the best way I can kind of put this, right? I don't know how your house is structured, but I bet you have a wall, and let's say that if we were to tear that wall apart, we would find fiberglass, that fiberglass insulation back there. Yeah. So normally you don't see fiberglass. We know it's there. We know it helps. We know it insulates, but you don't normally see or have this exposed fiberglass or the 2x4s that are holding up the wall. Now, if there's damage to the wall, well, those 2x4s, that fiberglass insulation becomes visible, but it's not typically visible. Same thing with the blood vessels. So normally, the inside of the blood vessel is not exposed to the blood, right? The depth of the blood vessel itself. Now, when the blood vessel gets torn, when it gets damaged, blood itself, plasma, has interaction with the underlying tissue of that blood vessel. And that triggers, again, the intrinsic. Intrinsic kind of means inside. So things inside of the blood vessel itself, not in the hollow area of the blood vessel, but if this is representing the blood vessel, my hands are representing the blood vessel, not in the lumen, not in the hollow area, but in the actual, I should say, in the actual tissue here. Right? So factors inside, intrinsically inside of the blood vessel, if blood vessel is damaged, plasma comes into contact with damaged tissue, that triggers the extrinsic pathway. So very similar, but now we have tissue factor as well. So tissue factor would be the external part of the blood vessel that normally faces out of the lumen. Right? So again, as we mentioned, both of these are usually occurring simultaneously. The big distinction would be, let's say, blood clotting outside of the body. Right? How can blood, if you lost the fight, you got punched, bled on the ground, blood will clot even when it's not in a blood vessel. So again, that would be a similar pathway, but not something that's intrinsic to the blood, right? So, or let me rephrase, it's the similar pathway. The factors that are necessary to clot are already intrinsic into the blood. So looking at these factors here, I'm not going to ask you to know these. It's again, so it's a biochemical pathway. So basically 12 initiates 12A, which initiates 11, which initiates 11A, 9 with the effect of 7A, with the effect of calcium, trigger 9A, and it just kind of keeps going on and on till we get to our prothrombin activator. So kind of what I was trying to discuss here, hopefully this makes a little bit more sense. So the extrinsic pathway is initiated by thromboplastin or tissue factor, factor 3. So factor 3, tissue factor, right? That's the actual activator of the extrinsic pathway. Right? And where do we get it from? From tissue cells. So normally let's say these blood cells are not going to normally be exposed to stuff out here. So out here would be our tissue factor. And once these cells come into contact with cells that they're not supposed to be normally into contact with, it triggers in this extrinsic pathway. So clotting is initiated by a factor outside of the normal blood supply, blood vessel, bloodstream. Intrinsic pathway is initiated by chemicals inside the blood responding to exposed collagen fibers. So this is, again, we break the wall, we see the 2x4s, we see the fiberglass insulation, things that it's not normally supposed to be exposed to. That's what triggers the intrinsic pathway. So collagen fibers. And again, we're going to address these very heavily when we cover blood vessels themselves. So to make our story again short, simplistic, we had to arrive at our prothrombin activator. On the left through the intrinsic, on the right through the extrinsic, we arrive at prothrombin activator. Once we're there, we have a singular path now. It's not two separate pathways now, it's a final pathway to the end. So we have prothrombin activator, two ways to get to there. Once we have prothrombin activator, this becomes a common pathway to thrombin. So prothrombin before thrombin will activate to form thrombin. And then thrombin will be the initiating sort of precursor to the final fibrin mesh. So basically we have our red blood cells. We have this mess of fibrin, like spiderweb, this sticky spiderweb strands. So how can we envision this? So let's say you play a trick on somebody, right? And on the door, you put like sticky duct tape with the sticky side facing inside, and you put, you know, a strand of duct tape, another strand of duct tape, duct tape, duct tape. So as people try to leave a room, the first person is going to get stuck to that duct tape, right? And because they're stuck, they're trying to kind of wiggle and get between the spaces. People behind them can't move through the doorway because they're blocked. So I don't know if that makes sense. Hopefully it does. But in essence, all we're trying to do is adhere to the red blood cells. We don't want them to get lost, to leak out. We want to kind of trap them here, and we want to slow down the loss of further blood cells. And that's the idea of this fibrin mesh. So the fibrin mesh is kind of like sticky spiderweb, fibrin mesh, sticky spiderweb sticking to the red blood cells and making it more difficult for others to go through that injury. So it works, right? So I bet you've had many cuts and scratches, maybe stitches. You haven't bled to death, right? So you can thank this intrinsic, extrinsic pathway and this eventual fibrin clot for keeping you alive and keeping you healthy. So again, in sort of word format here, so we got the intrinsic, extrinsic path to prothrombin activator, which initiated thrombin, which will then be part of the pathway to initiate our fibrin mesh. And once we have that, it's good, right? We're set. Now, there can be some, we know this is how it's supposed to happen. There can be some situations where once we have initiated the clot, we have to address that, right? We can't leave that clot in there all the time. So it must be dissolved away. We must then go back and heal the blood vessel properly. But we do have some hemostatic, or I should say, homeostatic disorders, hemostasis disorders. So two very related terms, thromboembolic conditions. Thrombus. So thrombus is a clot that develops and it doesn't get dissolved away. It doesn't get removed. So in essence, you have a clot on the inside of a unbroken blood vessel. So in and of itself, the thrombus is not necessarily problematic. It's not hurting anything, it's not harming anything, but what it does basically is it clogs up then the actual lumen, the hollow space of the blood vessel. So it makes it more difficult for blood to flow through there. We can start to have blockages, that kind of stuff. So it's not good. So we need to avoid this. The body needs to go in there and remove and make smooth again these walls of these arteries and veins there. Now, if the thrombus, if this clot basically breaks off and now is circulating freely throughout the body, this becomes dangerous. This is what we call now an embolism or an embolus. So the embolus is a thrombus, a clot that breaks away and flows freely in the bloodstream. So it's floating around with the red blood cells, with the white blood cells, with the platelets. And again, in and of itself is not problematic. When it becomes problematic is if it gets into a very small capillary or it clogs that capillary and it does not allow red blood cells to transport oxygen, nutrients, to remove waste, that kind of stuff. So we always associate embolisms and embolus with strokes, right? When people have strokes, it's normally because of a blockage. So this can lead to serious complications, right? So again, disorders because they're not supposed to be there. Yes, they were supposed to form if necessary, but they're not supposed to form if there's no damage. So the problem can be in the clotting cascade. Maybe we triggered something that was not supposed to be triggered. We make fibrin, or maybe we made fibrin the way we're supposed to, but it was not removed and sort of dissolved when it was done. So we'd have to do further investigation to see how or why these thrombi are developing. So again, this is when we basically have too much clotting. Now, if there's that penia again, penia, deficiency, poverty, poor. So a bleeding disorder can happen when there's not enough blood clotting. So thrombocytopenia, hemophilias, and again, any type of liver function is not producing the proper amount of clotting proteins can all lead to bleeding disorders. I do have a video here, some right up my alley. I do a lot of work with vipers, with venoms, that kind of stuff. So I'll upload a video that shows basically the mechanism. So we know if you're a venomous snake, a rattlesnake, a cobra, a viper, you have to inject this cocktail of venom into your prey. Well, what does the venom do? How does it work? Some venoms cause the prey to bleed internally. Russell's viper is the opposite. Russell's viper is very, very notorious for triggering a massive amount of blood clotting. And the blood clots lead to thrombus, emboli, and again, it's a mess of clotting. So I'll show you the video, I'll upload the video, check it out, see what you think about that. So yeah, that's the video there. All right, so with that, let me stop this presentation. So this would be the end of the, I should say the platelet discussion. I'll stop this video and then I'll record next the video on typing and transfusion and that kind of stuff. So that's a neat section as well. So look for this video and the associated videos on the clotting cascade, maybe on the forming the clot, and then on the clotting of what we call venom-induced clotting. Right? So keep an eye out for those. All right, so let me stop this here.